Of the patients who achieved a partial response in the SELECT trial on lenvatinib, most of these responses were significantly durable. They lasted for very many months and even longer than the 18-month progression-free survival, obviously. Um, in practice, outside of the clinical trial, sometimes patients can get a clinical benefit for even longer if the single sites that at the time of progression are able to be dealt with just radiation or surgery. So this is a drug now that can be used for an extended period of time in patients. Unlike other cancers where the duration of exposure to a drug might be on the order of just weeks to months, with patients with thyroid cancer being on lenvatinib for anywhere from months to years, it became very, very important to be able to manage toxicity. The major toxicity associated with lenvatinib in differentiated thyroid cancer was high blood pressure. And for that reason, 63% or over 60% of patients had to reduce their dose from the starting dose of 24 milligrams down to either 20 or 14 milligrams within the first 2 months. And so these patients actually had to have a dose reduction, but in spite of that, did very, very well. Additional studies are ongoing to see whether or not we could actually start at a lower dose instead of starting at a higher dose and still get the same efficacy, but the data is not available at this time. To other toxicities that are seen in patients with lenvatinib include loss of weight, particularly loss of muscle mass, so sarcopenia, as well as diarrhea. And of course, all of these can be interconnected. Fatigue is also another significant side effect. I personally find that the diarrhea is often to blame for all of these because when patients are not controlling the number of bowel movements they have a day, they tend to get dehydrated, get more fatigued, sometimes have more depression, and all of these things actually can lead to decreased absorption of the drug and even can lead to less efficacy. So it's really important that patients know how not only to control their blood pressure, which is the thing you have to worry most in the first month or two, but also long-term know how to manage the diarrhea, either with using Imodium, diet control measures. In addition, what we do to help patients maintain their weight is to actually have them do strength training. The strength training helps counteract the sarcopenia effect of the lenvatinib and can be very, very helpful. We prefer not to use dose reduction to help manage side effects, but occasionally that can't be avoided, in which case we often start at 24 milligrams and then go down to 20 milligrams. The most common cause for me for dose reduction in my clinic was patients who had high blood pressure that could not be controlled with 2 or 3 agents. Occasionally, patients also need, even more often, dose reductions. I tend to use dose interruptions. That is a very, very useful tool and can be used a little bit more commonly. And it's not uncommon, especially given what I just said about the GI toxicity, that a 2-week holiday, sometimes in patients who've been on the drug for a couple of years, can really help to sort of reset the GI tract, help the diarrhea calm down. And then many times the patients can restart at the same dose, still get the same benefit, but now their GI symptoms are much more controlled. So rather than using dose reductions, we try to prefer to use dose holidays. The exception to that is dose holidays doesn't help you figure out what blood pressure medicines you need, because of course, as soon as you restart it, you're going to need to start the blood pressure medicines again. But it is important because many of our patients are on multiple blood pressure medicines that if for some reason they go on a dose holiday for GI toxicity, it's important to remember that they need to stop the antihypertensives that they were on because of the lenvatinib, or they might end up hypotensive and have a negative effect.